अस्सलाम वालेकुम जी, गुड मॉर्निंग एंड वेलकम। हम आज का सेशन शुरू करते हैं। आई थिंक इफ़ एनीबडी फील्स एवरीबडी फील्स कंफर्टेबल, ये हम बाइलिंगुअल कर लें, उर्दू इंग्लिश जैसे भी लोग करना चाहें। आई डोंट थिंक एनीबडी स्पीक्स एक्सक्लूसिवली इंग्लिश में, तो जो आप लोग कंफर्टेबल करें। मेरा नाम अदनान ख़ान है, मैं हेल्थ रिसर्च में काम करता हूँ। इट्स माई प्लेजर टू इंट्रोड्यूस दिस सेशन on finding what works. I mean, इस वक्त we are reclaiming the promise of family planning, and what does that mean? उसका मतलब जो कि आप सुनते आए हैं, बहुत सारा डूम एंड ग्लूम, जैसे डॉक्टर फरीद ने कहा कि हम हर साल सालाना मरसिया पढ़ने आते हैं. Let's not do that. There is a lot of progress that has happened. We've just not been able to capture it. ये हमारी problem, and that's a problem that we should probably discuss. So I'm going to actually let our presenters start, and then hopefully क्योंकि लोग कम हैं, तो we'll have more robust time for discussions. Our chair is Professor Mohammad Waqas, who's at Foreman College. He's the director of their Population Research Center and associate professor of sociology. His work has been extensive in population research, social statistics, and has published widely in prestigious journals. He actively chairs sessions at population conferences and conducts workshops. And in addition to his regular duties as an academic. Our discussant is Miss Iram Kamran. Iram has been with the Pop Council for a very long time. She heads their analytics and research, and is an executive council member for PAP. With that, I would like to ask our first presenter, Mr. Junaid. Junaid is from Green Star Social Marketing, and will talk about synthesis of dose-response relationships in scaling high-impact interventions in urban, public, and private sector facilities in Pakistan.
Thank you, Dr. Adnan. So I'm here representing a program called the Challenge Initiative, or TCI. And it's a program which is being spearheaded by Green Star Social Marketing in Pakistan. So TCI is a global program which is currently being implemented in 13 countries all over the world. It's housed centrally and managed centrally by Johns Hopkins University in Baltimore. And it's managed in a form of, so each country or a group of countries is classified as a hub. So for example, so the program was originally piloted under the name Urban Reproductive Health Initiative in 2015, or URI. And in URI, initially the first countries were from East Africa, Kenya, Tanzania, and Uganda. And then we had a few countries from Francophone West Africa and Nigeria. So these were our three original hubs. And then India and Philippines were added around, I think, late 2016, 2018. And then Pakistan is the newest hub in the program, which joined in June 2022. So this, just for the sake of information, so this cycle of the program is due to finish in December 2025, and the next cycle of the program will begin. And Indonesia and Bangladesh are expected to join as two new hubs. Thus far, so the program works towards additional clients as their primary outcome and primary metric, and thus far, the program, with the support from Gates Foundation and Bayer, has generated around 7 million additional users globally. How the program operates is the program works with existing public sector infrastructure, predominantly with a strong focus on urban areas and urban slums, because the program's hypothesis is these programs have, like the focus has historically been, especially in LMICs, has been on rural areas, and with large, increasing rural to urban migration rates, it's about time that we start focusing on urban areas as well. So TCI implements what we call a set of high impact interventions, which we'll go into detail a little later. So thus far in Pakistan, we're currently implementing in 15 cities. And these cities were, so how it operates is, so when TCI came in originally, they had an inauguration with the national government, and then we sat down and worked with the provincial governments of Punjab and Sindh, and then the districts sort of self-selected into the program, and these were the districts which had the highest population. So in Sindh, we have the 7 districts from Karachi, and then we have Hyderabad as the 8th district. Then in Punjab, we have 6 districts, which includes Lahore, Gujranwala, Faisalabad, Rawalpindi, Multan, and Khalilwan, right? So these are the most populous districts in this, and have the highest proportion of urban population. And then we have Islamabad as the 5th district. Most districts except for Multan and Khalilwan joined by September 2022. Kimadi joined the program in I think May 2023. Which is around the time that the district was sort of demarcated or separated from Karachi West, and then Multan and Khanewal joined the program in October 2023. So it's a 3-year implementation cycle with the districts first. When they enroll into the program, there's a startup phase where we work with the government partners at the district level, and then we start implementing our high impact interventions through the government's infrastructure. And eventually, once the 3-year cycle finishes, the districts sort of graduate. And after that, the TCI sort of takes the back seat, and then the government takes the lead in implementation, with the idea that the high impact interventions are institutionalized in policy, budget, and the work plan. So in Pakistan, these are the high impact interventions that we're implementing. So in reaches, they refer to dedicated family planning days in public sector facilities, whether it be BHUs, FWCs, well, not so much FWCs, but BHUs, RHCs. Outreaches are pretty self-explanatory. Family planning integration is integration of family planning into non-family planning areas, which includes vaccination, immunization. So a client comes in for immunization, and if they are counseled on family planning, and if they decide to take a method, then that's something that we would count under family planning integration. Postpartum and post-abortion family planning are very self-explanatory, so is on-the-job training. Whole site orientation is an intervention where we go into the facility and train each and every member of the facility, including the janitorial staff, on family planning methods, because a lot of males, especially in BHUs, they're not really allowed to come into the facilities, so they're just sitting outside. And that's an opportunity for the guards and other members of the clinic to interact with them and talk to them about family planning methods. This is one of the initiatives that's actually been appreciated by the government a lot, and they've, specifically in Punjab, it's been institutionalized. They have developed manuals, and they're now implementing it on their own as well. Facility makeover refers to an intervention where we upgrade the infrastructure of the facility. It's around, I think, for each facility, it's around 2 million that's spent on renovating it, and the facilities are identified based on client footfall. Health workers, so it's training of health workers on family planning methods, as well as recruitment of community health volunteers where there are no health workers available. So for example, if there's a facility with a large catchment area and there's only one LSW there, so that's where we'll identify that there's a need, and we'll recruit some community health volunteers to fill in the gap for demand generation. So the advocacy and demand generation ones, the rest of them, they're quite self-explanatory, so I won't dwell on them. So the 4 high-impact interventions that we'll focus on in this study are health workers, makeovers, in-reach, or as we call them, family health days, and outreach, which includes satellite camps and mobile service units. So thus far, the program has engaged around 5,448 health workers, which includes our health volunteers as well. 66 government facilities in 15 districts have been renovated. We have these, so thus far we've had around 10,112 family health days, serving around 600,000 family planning clients, and around 9,000 outreach, including satellite camp and mobile service unit service delivery channels, which has served around 406,000 family planning clients. So our main objective was, because these interventions are layered, it's hard to isolate the effect of one intervention. So our main question was, in terms of like, what is the effect of exposure to single versus multiple doses of high impact interventions compared to control districts where no high impact interventions, or as we call them, highs, are being implemented. So the data that we use is we use the data from the CLMIS, for DOH, PWD, and PPHI facilities. We identified 7 control districts based on urban population and baseline patterns. So in Sindh, we identified Larkana, Khairpur, and Sakkar as our control districts, and in Punjab, Attak, Bhawalpur, Sheikhupura, and Sialkot were our control districts. So we use data from around June 2020 to June 2025. So June 2020 to May 2022 was the pre-intervention period, and June 22 to September 2024 was our post-intervention period. For data analysis, we used the Welch and Over test and the negative binomial regression to assess the efficacy of one high over the other. So when we look at, so when no high is being implemented, so 0 is referring to the baseline period for our 15 districts as well as the control districts. So when no high is being implemented, so the average monthly client volume for a district is around 2,446. And when one high is being implemented, it increases to around 3,000 for all methods. There's a slight increase on the second dose, around 3,200, and the third, but it drastically increases when the fourth high is added. So which is sort of like culmination of everything that is happening. So you have the makeovers, the facilities infrastructure has been upgraded, you have outreach service delivery, you have in-reach service delivery, and then of course you have health workers. So the combination of the 4 is yielding the best results. We see a very similar story when we look at short-acting methods as well. It sort of jumps to around 3,286 at the 4th dose, with gradual increases from the first to the 3rd dose. A similar story for long-acting methods as well. So when no high is being implemented, it's around 812, and it increases gradually to 1,000 with the first and the first to the 3rd dose, and on the 4th dose, it increases to around 2,544. A similar pattern was observed for permanent methods as well, with around 88 clients at 0 or the control point, and it increases to around 220 with 4 doses. So the results of the negative binomial regression, so when we look at the incident rate ratio, it's when we look at short-acting methods, so we don't find significant results with the first and the second high-impact interventions, and it starts getting significant around the 3rd dose, so around a 1.31 ratio, and then when it goes to 4, so almost twice as likely to yield better results or double the results with the 4th dose. Similar story for LARC. In fact, it's even 3. It's the likelihood of having greater client volume is at 3 for LARCs, and then for permanent methods, it's around 2.5. And when we look at the picture overall, it's around 2.47 on the 4th dose. So the findings of the study, so it's globally we don't have this evidence with TCI as well. So this was the first studies that looking at the dose response relationship between the highs and the client volume. And layering of highs makes sort of intuitive sense as well, because CHWs, they sort of serve as the pivotal point that works around the other 2 highs. For example, they mobilize the demand for the outreach and the satellite camps as well as the FSDs as well. And then makeover sort of serves as this overarching intervention which increases client volume, not just for family planning, but OPD as well. So you get a lot of clients flows from OPD to family planning as well. So, and specifically in urban areas, like with so many barriers of access and information, so layering of these highs sort of serve both, help you address both demand side and supply side barriers. So our recommendations are that the government should adopt these fully layered high impact interventions as standard practice. They should institutionalize them within the government systems. So thus far what we've tried to do is we've tried to institutionalize them within the policy, within the budget, within the Burke plan. Now the most important thing is to follow up on the implementation, which is what we'll do predominantly in the next cycle of the program. And the last and perhaps the most important point, strengthen and consistently finance these high impact interventions, specifically with the turmoil or the structural changes that the Punjab government is currently undergoing. So it's imperative for us to make sure that financing for these high impact interventions persist. Thank you. Thank you so much.
Any questions that people have for Jay?
My question is कि आपने इन जगह के साथ बलूचिस्तान को क्यों फोकस नहीं किया?
So as I said, the districts, they self-selected into the program. So it's through the provincial governments that we implemented. I think the challenge in Balochistan would be in the future, if I were to say. I think in terms of urban populations, because that was the primary focus, I think Quetta would be the only intervention city. But it's again, they self-selected into the program. So it depends upon the willingness of the provincial government and the local government to come to the program.
You just mentioned that the baseline year was 2022, but what was the trend of the footprint of clients before, well, like in 21, 20, so that it can give us a kind of look that how it was changing before?
That's a very good question, actually. So we've done several time series analysis. We specifically do interrupted time series analysis. Now, the baseline period is particularly interesting because our baseline period is 2020 to early 2022, which coincides with COVID. So in COVID, most of the Department of Health facilities were not delivering family planning services. And so the baseline period slide is slightly misleading because then you see this trajectory and slightly it changes upward, which sort of coincides with the period of the intervention. But when we look at the control districts, so our trajectory is slightly higher than those of control districts. PWD is interesting because there's a bigger stock issue there. So because they were delivering services during the COVID period as well, but the level of supply has steadily declined in the intervention period, whether it coincides in Punjab, it coincides with the structural merger with Department of Health. In Sindh, it's a larger issue of commodity security not being there.
You said that you have been working in the lady health worker areas, and in the larger areas you also hired the community health workers. So what did you measure any kind of difference in this uptake in the LHW areas and the health worker areas?
So we actually published a paper recently on this. So we weren't able to isolate it like that, but we were able to specifically identify when community health volunteers were recruited. So specifically because we placed the health volunteers in both PWD facilities and sort of DOH facilities as well. In DOH facilities, we do see a marked increase because in the FWCs, for PWD, you have FWAs who are dedicatedly working for family planning, right? So in PWD facilities, we didn't find a lot of impact for CHVs, but in DOH facilities, we found a lot of impact for CHVs because LSWs are overburdened with other health areas and other campaigns. So I think it was around a 10 to 20% increase in their facility level client volumes where health volunteers were placed.
Okay. So you did not see at the community level, there wasn't any kind of study or
No. So because
this was found.
No, so because we use HMIS as our primary data source, we didn't really do any community-based service. However, there is a third-party evaluation currently being done by ITAD. I don't know if they specifically went into the communities, but that was a part of their qualitative aspect, so maybe we'd capture that.
How do you define a large catchment area? Because the lady health workers have a defined catchment areas. So, and you said that your volunteers were working in department DOH facilities and FWW facilities where lady health workers are also there. So, how did you define that this is a large catchment area and we need?
I think it was linked with population density. So, for example, particularly in Karachi, because that's where the health volunteers program was initially pioneered. Because so for example, in dense areas of Karachi, you have one lady health worker or two lady health workers serving that area. Now, theoretically speaking, geographically speaking, the coverage is enough, but in terms of the number of population or the number of people that they had to speak with or they had to do household visits, that's where we found that those areas are being underserved, and that gap can be filled with CHVs.
The first question is, you had four high impact interventions that pretty much address every layer of what needs to be addressed in a community, starting with the revamping of the health facility there. And I'm thinking that includes providing them with enough contraceptives so that they can spread them around in the community. And
No, unfortunately, no. No.
Okay, so what did that actually include?
So when we talk about revamping, so for example, I don't have those in my slides, but there were facilities. I think if you were there in the earlier session that Dr. Samin was talking about, some of the facilities were just completely dysfunctional, right? So for example, there were a lot of facilities which did not have the necessary equipment for service delivery. There were no washrooms, there were no functional washrooms. The infrastructure was just not sufficient for service delivery. So it's sort of a revamping of the entire facility as a whole.
Of the place. So my question number one was, since you're operating in the community also, which means you're doing outreach and then you're doing facility related work also, did you at all measure the difference between the two, like which one was more effective between the two? The community outreach, like the unique contribution to that effect that you produced.
That's a very good question. So that's a question that we've been mulling over for the last 2 or 3 years. So we tried to do this analysis multiple times. It's just because the way the interventions are rolled out, we did not find enough cases of, for example, because we need to find instances where only health workers were employed, or for example, where only outreach was being done, but no in-reaches were being done. So I think in the next 5 years, we may have enough sample, but we currently don't have the sample to conclude on this.
I would just make one small suggestion. If you could include client feedback service system where you could actually go to communities and those people who have taken up or have used or have been impacted by your interventions, maybe you could ask them which intervention was it that did it for them, or was it a combination of them? So that could be a good way to sort of collect that data.
Client exit interview at the facility.
Absolutely.
Thank you.
So your community volunteers, they were unpaid volunteers.
They were paid a stipend.
How much?
He would know. He's our finance manager.
1,000 per day.
Okay, so
For 15 days.
all right, so somewhat less than lady health workers.
Yeah.
And what was on average? What was per monthly referral rate from the community from them?
So it varied quite substantially with, I think, if I were to give a ballpark number, so on average, I think around 50 to 60, I would have to go refer to the paper for that exact number.
Adding to it, like based on your recommendation, you're recommending to the government that they should go with the your model, or they should strengthen the LHWs?
Bit of both. So strengthening the LSWs is critical because the rest of the highs, specifically those around service delivery, are dependent upon if, like for example, the LSW is not mobilizing demand for those services, then there's no point in going into the community and doing those outreach if the client's not going to be there. So LSWs are absolutely pivotal to the implementation of the interventions.
Junaid, can I ask?
Gigi, please.
Yeah. So you are mentioning here that these are the priority themes selected by the government. What does that mean?
So I think this refers to the themes that were identified by the CCI in 2018 or 2019. So we try to align the intervention with these broader
I think
themes.
it should be clearly articulated because when you say or write it like this, so we understand that probably you would have prior consultations with government and they would have identified these areas, and that is why I was getting confused at how could they say the contraceptive commodity security. So it should be probably a little clearly defined. Other thing is, I think it's quite complicated model, and obviously it would have a lot of contribution at the community level and the service uptake. But I think probably you have also touched upon it slightly, but I would say that you should be able to analyze or define which particular intervention contributed or contributed to what level, or what's like change. You can link the change like attribution kya hai uski, right? So I think when you say postpartum family planning, post-abortion family planning, do you mean service provision or counseling? Both. And okay, one of my question was that LHWs are already trained on family planning, no?
So it's a good question. It depends. So yes, they are trained, but because they are overburdened with other health areas, that knowledge is not as there as it should be.
So did you conduct any assessment prior to this to assess their knowledge level?
No, there was no baseline assessment. No.
Oh, so that was on the basis of assumption that they
Yeah,
should be. Okay.
All right, thank you.
Thank you.
You are.
Thank you, Junaid. That was very interesting, and I think we'll continue straight into private sector. Delivery of services with self-care models to address contraception need vis-a-vis injections by Japaigo, and I think that would be Ms. Kamal is going to present that.
Thank you so very much. This is Kamal Qayyum. I am representing Japaigo. I'm presenting the results of a study which we recently concluded in Punjab. I think the finding of this study will interest to many of you who are discussing since this morning the LHW model, as well as urban and rural uptake of contraception. So there are some interesting findings around self-injection of DMPA-SC. So I'm sure many of you already know. Those who don't know, DMPA-SC is a hormonal injectable contraceptive with specific feature that this is something which women can learn to inject herself and can meet their family planning needs at home with little training in the beginning. So this injection provides 3 months contraception, and it can be injected every 3 months. It is injected subcutaneously, and it's very highly effective. It is approved by WHO and already implemented in 64 countries as self-injection injectable contraceptive. So here the context starts why we did this study in Punjab. If you look at the demographic health survey 2017 and 18 method mix data, that clearly shows that the injectable uptake in total method mix is less than 2%. So and at that time in this system, only provider injected DMPA-IM is available. So currently Punjab does not have DMPA-SC in their basket of choice. Only DMPA-IM is available. So Government of Punjab was interested to increase their MCPR, and they asked us to conduct that study whether women will be accept this as self-injection or not. So that was the background of this study. We collected our data from Kasur and Khanewal. These are two districts which belongs to two different geography in Punjab, one from the central Punjab, the other was from the south Punjab. So only two districts were included in the study. The prospective cohort study, it was a longitudinal study. There were many objectives, but here for this presentation purpose, I will only focus on the main objective of the study. It was to compare 12-month continuation rate for DMPA-SC and DMPA-IM among married women between the age of 18 to 49 in two districts of Punjab. That was the main objective of this study. So there was study eligibility criteria. We selected women as per this eligibility criteria, which was women should be married, because we were conducting this study in private, mainly public health facilities. So they are offering services only to married women. So we specifically define our criteria as per the those service delivery model. So married women between the age of 18 to 49, those who were medically eligible for injectable contraceptive, they wanted to avoid pregnancy for at least 12 months. And they live in the same study districts because we wanted to follow up these women in their home premises or telephonically. And those who wanted to be contacted telephonically or home visit during this 1 year. These women we included in the study. After considering all statistical consideration, we come up with the sample size of 1,000 women whom we will follow up in this study for 12 months. Eventually, we enrolled 1,009 women in this study, 506 in IM study arm and 503 in SC study arm between the time period of 2024 to 2025. We collected this data from 41 health facilities in Punjab, including Department of Health facilities as well as from PWD's health facilities. And there were only 6 health facilities where private providers we also included in the collected data from there. Our trained family planning providers from these health facilities who were specifically trained how to enroll these women in the study and how to train these women on self-injection counseling. They were, that was the main prerequisite that only these service provider will recruit women for this study. If there is any transfer or some service provider is not available, then as per our standard operating procedure, we had to stop the data collection at that health facility, train the new service provider, and then we used to resume the data collection process. So we very rigorously followed that criterion to meet for the study recruitment process. So all trained service providers recruited women for this study. We conducted intake interviews as well as follow-up interviews on every 3 months after the intake dose. All interviews were in person or telephonically as per the client requirement and as per her consent. The first interview after taking the first dose was conducted within 15 days of that first dose. And the follow-up was between 120th day to 130th day of subsequent dose. So we were very mindful of following that procedure. So we should not be reminding those women to inject their second dose or third dose. So we were contacted that women after 120th day of that. Okay, so for the analysis we run for continuation rate, crude continuation rate was calculated and Sankey diagram to visualize shift in injection modality. A competing risk regression model we also used to estimate subhazard ratio for discontinuation and adjusting for socio-demographic factors. So that was our pathway to injection when a client entered into the facility and she is eligible for injectable contraceptives. There were 2 injectables offered to that women, DMP IM and SC. IM with this option that provider will inject you and give you a follow-up date to come for subsequent doses. And for DMP SC there was option that you can either inject it yourself and get it trained, or you can also take it from the service provider. But women who obtained that self-injection training, they were given so what was it then? After receiving that training, we were assessing that woman whether she is confident to manage those doses at home or not, whether she is confident to follow all self-injection steps or not. So after assessing those competency and confidence level, women is given that opportunity to inject it in front of the provider in her supervision, to inject the first dose herself. There were many women who tried that doses herself, and there were many women who asked the provider to inject it for themselves. So both options were there, but that was not the criteria to exclude these women from the study. We took those women who wanted to participate in that study. And okay, I'm distracted by 2 minutes. Okay, so so that was the criteria where that was the subgroup of injectable contraceptive users where we recruited these women in this study. So I'll quickly jump to the analysis and our findings. So when we look at the profile of these cohort, what we look at, women in the study came from all age groups with average age of 31, from all education background and from all income background. Injectable contraceptive users enrolled in the study spanned all these demographic characteristics. So based on that was not statistically significant. So initially what we recruited, they belongs to all these demographic and background characteristics. So here it is important to note that only 19% had education at grade 11 or above, and education level was fairly evenly distributed. Women from all wealth quintile, with just 16% belonging to the wealthiest quintile, also participated in this study. So most had at least 2 children and had used family planning before the study. Contraception history was there. 48% women had a family size of 4 and above children, and 75% of women were housewives. About 70% had never used contraception. There were 30% women who never used family planning method before. Notably, in the last 2 years, 29% had used injectables and 40% used other method. So in both groups, we had this fairly distributed characteristic in both groups, where we also had new users and previously users of other methods. So this slide explains what is the continuation and discontinuation rate for both groups. Here I would like to draw your attention to these blue bars, the longer bar in 3 charts. This shows the continuation route. This is the crude continuation rate, and it shows that 20% point difference between 12-month DMPA-IM continuation, that is 49%, and DMPA-SC continuation, which is 69%. However, it would be misleading if I just present the continuation rate as it is, as a crude continuation rate, because there were few variables, particularly stock out of DMPA-IM was one of the most confounding variable that was impacting the continuation rate of both injectables. So how did we overcome that challenge? And mostly this stock out was in Department of Health facility where DMPA-IM was stock out. In other site where expected supplies were maintained, we observed a 7% point difference between 12-month DMPA-IM continuation, that was 67%, and 12-month DMPA-SC continuation, that was 73%. The subsample does not have sufficient power to detect statistically significant difference of this magnitude. When we also compared these 2 groups where the stockout was persistent, we found the 60% point difference in the continuation rate for these injectables. So IM was 7%, and DMPA-SC continuation rate was quite high. So the stock out is a real challenge in the real world. DMPA-SC, after adjusting for stock out and individual household characteristic, what was statistically significant? DMPA-SC is associated with a 26% lower likelihood of discontinuation than DMPA-IM, and past injectable use is associated with 41% lower likelihood of discontinuation than no FP use in the past 2 years. Another interesting finding that we found out that obtaining FP services at a rural health facility is associated with a 42% lower likelihood of discontinuation than an urban study site. One of the major factor which I would say in this study, we were providing 3 units to take home for all those women who were enrolled in this study to continue and self-inject at the home health facility, at the home premises by herself. So in rural health facility where women also took those doses at home, they also manage it as a self-injection. And at the end of the study, what we have found out, there is a 42% lower likelihood of discontinuation for DMPA-SC than the other urban health facilities. So additional factors that were not significant status in our multivariate analysis, that was women's age, education, number of children, wealth quantile, reproductive empowerment, self-confidence, method index information. So injectable discontinuation was mostly a personal choice in both groups, and mostly women were discontinuing because of the concerns of health or side effects. So that is, I would say, a consistent finding. When we look at the self-injection, 8 out of 10 DMPA-SC users tried self-injection during the 12 month. There were 34% women who always self-injected from the beginning till end, and there were 20% women who never self-injected since the beginning until the end. There was a 24% women who were a mix of SI and other injection. They were seeking support from others. They were injecting next dose. They were injected by herself, and so that was a pattern we also observed. We also observed that at 1 year, 74% of women were self-injecting, and another 12% were injecting outside the facilities with the support of others. So initially, when 41% women at the health facility first dose, they self-injected, eventually we observed that 74% were managing self-injection successfully at home. And initially, 59% women who opted for provider administration for the first dose, eventually 13% maintained that trend, and not everybody was opting for that option. So many women from this group also joined the self-injection group. And then only 12% women were self-injecting with the support of others and also seeking support from LHWs. So what do we conclude? Program should, self-injection is something which is doable, acceptable in the community, and women can inject regardless of their background characteristics. Multiple doses that we offer to women to self-inject and tried at home by herself, that turned out a very good support for women, that ensured that supplies are there and they can self-inject. Also, services should not discriminate women on the basis of their background characteristic, who can inject and who cannot inject. So all women can do that, and in all geographies it can be successfully implemented. Thank you so very much.
Very interesting study, very encouraging results.
Thank you.
I particularly found the differences between the urban and rural continuation rates to be interesting. What were the differences in the reasons that they gave for continuation between urban and rural clients?
42%, I think you are referring to that facility. One of the reason is that they always have family planning needs. They cannot access those services, and they cannot afford it, because going to that health facility is one of the challenge for them. When we were providing 3 units to take home, that was a very, what we observed in our observational study. We also had that study during this time. they kept it, they stored it very religiously in their home setting, away from the children, and they were maintaining that doses at home. So there was a commitment and there was a need for contraception. So perhaps those availability of those doses ensured them to meet their needs. That was, I think, one of the major reasons. So access, availability, and there we were meeting.
Thank you very much. We had two but very powerful presentations. I would request Ms. Iram Kamran to sum the findings of this session.
Thank you, Dr. Adnan, and Assalamu alaikum, everyone. I know there's lunch has been served outside, so you'll be getting anxious. But I would like to congratulate Junaid and Kamal. You presented very well, and the studies were very powerful, really. And I must appreciate both of you for on behalf of your organizations, which is contributing obviously in meeting the unmet need of family planning in Pakistan. So good work done. I'm not sure how many students are here. Thank you. And I'm very happy that you are from Balochistan. And I was really impressed that you are raising your voice. You are raising your concerns since morning. But unfortunately, we do not have much answers of your questions. And we don't have any concrete pathway to improve indicators, and especially in Balochistan. Before going or synthesizing what you have presented, I was just thinking that why and to whom we are presenting these findings. I was sorry to be a little critical, but I was thinking since yesterday we are holding this conference in an institution, education institution, so that more and more students can get benefit of it. But unfortunately, they are not there. Secondly, what major part is missing is our policy makers. So why, kisko hum suna rahe hain? Basically, they need to be there to listen, and students need to be there to absorb what we are going to transfer to them, and they should be learning out of it. Anyway, with all these limitations, which should be addressed in hopefully next conference, we should focus on that part. But I would say that coming to Junaid's presentation, I was like, I know TCI, I know initiatives, but you have very clearly articulated and described that how you are going about it, about this TSI. This initiative is very, very good. And you have presented all good results, obviously. One and two suggestions I gave, how you should be mentioning or elaborated on this government, like their consultation sort of thing. But I think results are obviously very compelling. If we talk about the program, the only thing I see that the program is concentrated on cities, on urban areas. You're not going to the rural areas. So who is going to take care of those areas where unmet need is very high? Right? In urban areas, I always see that there's a great access to women. They have little bit empowerment also. So when they want to use, they can always go to seek services from. And there are a lot of services available out there in the public area, in the city area. So if you are again going to cities and you are training the cadre who is already trained. So I think we need to be very careful while designing such models that where actually these are needed. This is my personal observation and personal take, because our urban areas obviously they need services, but not to that extent as hamare rural areas ki women, because we always say when we analyze ke unmet need is higher in rural areas of among the poorest quintile. Right, so I think that is my one. Otherwise, obviously, results were very compelling. Coming to Kamal's study, I also know वही again वही बात है ना कि वही लोग हैं जिनको पता है कि क्या हो रहा है और वही सुन रहे हैं और वही कह रहे हैं, पता नहीं किसके लिए कह रहे हैं, तो थोड़ा सा हमें आई थिंक ये वो होने की ज़रूरत है. एनीवे जो DMPSC है एंड DMP है उसमें मुझे कुछ थोड़े से क्वेरीज थी, वी कुड नॉट आस्क यू, लेकिन आई थिंक वेन एवर इफ यू प्रेजेंटेड टू अदर फोरम्स तो प्रॉब्ली यू नीड टू क्लैरिफाई के आपकी यू मेंशन रिक्रूटमेंट, राइट? तो रिक्रूटमेंट इज़ अ चैलेंजिंग टास्क. ठीक है, तो आई वांटेड टू आस्क यू के डिड यू फेस एनी रिफ्यूजल्स बीइंग रिक्रूटेड by the service providers or by your team? So it's a critical thing. You need to mention that what kind of challenges did you face during this recruitment. I'm not sure that everyone was very much willing to be interviewed, right? So those kind of thing. And then I was also interested to know the discontinuation. आपने बताया कि there's a discontinuation. Discontinuation was high for IM, not for SC. So that was main thing कि why there's a high discontinuation in IM and not SC, and there is a switching again. So why switching? When you say switching, so to what method? Probably that's also important to cover that when switching happens, it is always positive to switch a method, but to what? If you are switching to one short-term method to another short-term method, it does not make any difference. It should be switching to short-term to long-term, ideally. So you need to unpack that and explain that, like, what's the pattern. And then I think poorest, what I gathered that the uptake of SC, DMPASC was the profile. I could imagine that women were mainly illiterate. They were from poorest quintile. 26% were from poorest quintile. So that means that the unmet need for family planning is there, because it's always high among poorest quintile. So what about the reception among richest quintiles? We need to also look at that. And when you present the result, you combined all 1009 women analysis जब आपने दिखाया, तो it should be by DMPSC, IM and SC. This comparison. But I could probably I missed that, but I see that there's a lot, like everyone was lumped together, so I was struggling to find out that what's the difference between this and this. And I'm sure कि आपकी जो intervention है, that is mainly focused on rural area, right? और urban भी है? Both. लेकिन रूरल एरिया तो है एटलीस्ट, राइट? हाँ, तो आई एम हैप्पी कि इट इज़ अ अच्छा. दीज वर माई लाइक ब्रॉड कमेंट्स, बट आई वुड से कि इफ़ वी फोकस ऑन आवर टुडेज टॉपिक, why we are here, that calls that this is the reclaiming the promise of family planning. So we have been discussing since morning that there's a lot of, like, when you see that we talk about negative things a lot, but I think we should have a positive angle, positive lens. We should, as Dr. Adnan said, that it's not that everything is ruining, यानी तबाह तो नहीं हो गई, things are improving in our country, ऐसे नहीं है. तो हमें we should use our positive lens. ठीक है, with positivity you can improve a lot. There's actually, the problem is the political commitment. Obviously supply side issues, demand is already there. तो हमें अपने जो supply side issues हैं, we need to channelize those. अब I don't know कि what's the answer of raising this political commitment. पता नहीं कहाँ से आती है, हमें नहीं समझ आई. Once there's a study conducted globally exemplar, this is called exemplar, this was conducted by Aga Khan, by Zulfikar Ali Bhutta was involved that. We were also partners, that is how I know about it. There, globally there are 2 to 3 countries, they pura ek extensive analysis hua, including Senegal and 2 more countries were there. So the one factor which came out that how did they succeed was the political commitment, nothing else, no funding, nothing else. So political commitment was there, which we obviously we lack. So I think हमें we need to search the answer, and I think जो अभी सुबह भी बात हो रही थी कि summit भी हो गई और events होते हैं, we talk and we go back. I think these talks are needed. If you don't talk about it, nobody is going to be notified. कोई भी नहीं ऐसे कहेगा कि भी I am responsible. At least we should continue talking. That look here, this is the great issue of our country. So I think I would appreciate if you continue talking about it at different forums. So I think I should stop here. Thank you so much.
Thank you everyone for being here. I would like to request Dr. Waqas to finally close the session with his remarks and some tokens of appreciation.
Thank you very much, Dr. Adnan. We're a small group of, the PAP is a small, very well-knit group. And I remember 2023 में अदनान साहब जो थे वो सेशन चेयर थे और मैं मॉडरेटर था और मैंने उनको इंट्रोड्यूस करवाया था with all the accolades that he has achieved. But today he has been most generous with me while introducing me. I'll keep my comments brief. There are a few things I did want to put forward. मुझे PAB conference में आने में बहुत ज़्यादा interest होता है because there I get, among other things, one unique experience, which is what the private sector is doing and the type of research and interventions that are being planned by the private sector and piloted. And those are always very fascinating. I see a lot of drive behind those. But I do find sometimes that in the enthusiasm of making an intervention successful, I think it comes at the cost of academic rigor sometimes. In the first paper, which is an excellent paper by the way, it was an excellent initiative and I'm all in favor of it, but introducing 4 interventions in which you include mass media campaigns and private counseling and lumping them up into this one effect, that's got a little bit of academic rigor issue. Designing a program in which somebody is supposed to take an intervention every 4 months, but you recruit people that are already willing to do that, already willing to get into the program, you give them recruitment into this program, and then you don't tell them when to introduce the intervention, but in 120 days you do give them a call to check whether they have taken their previous dose, which is also a reminder whether they're going to take their next dose also. Little bit of an academic rigor problem, but I'm going to be very honest here. This academic rigor is not lagging just at your end. This is not a criticism. This is, if it is anything, it's self-criticism, because Dr. Farooq is sitting here and he and I were having a discussion last night, late into last night, and we were talking about how lazy academics are because our motivation is presenting a paper or writing a paper, and we do just enough that is required to get through the peer review process, not more. So we are as guilty as probably anybody else is, because we are all a community in this. So from this, I will go into the next point, which is basically what I also observe in these conferences from what I do, and the 2 programs that were presented, which were absolutely fabulous programs, is the lack of community feedback and involving the communities into their own lives. All top-down initiatives, something that was going on globally, worked globally, we apply it in Pakistan, we think the community will take it, accept it, and go with it. Do we ever actually involve them? Why can't we involve them into this process and think towards participatory development, where they become participants, active leaders in their own development, be that family planning, or creating a water reservoir, or sanitation, or whatever. I am a big proponent of it. I feel that without having community on board, nothing can be achieved in the community. So, on a very, very thankful and positive note, I would just like to say that maybe we need to break our silos. Maybe the academics need to work with the private sector, and maybe the private sector and the academics and the governments really need to work with the communities. Not for the communities, not deliver services to the communities, but actually work with the communities. With this, I will just like to thank both panelists, the discussant, Dr. Saab, for inviting me. It was an honor to be here. It was a pleasure to have attended this session. With this, I conclude this session. Dr. Na, so over to you.